Bismillahirrahmanirrahim. Assalamu alaikum. I would like to introduce myself. My name is Professor Touseef Asghar. I'm working at Shalamar Medical and Dental College as Professor of Surgery. The topic which has been assigned to me is primary survey of the trauma patient. So let's start with the presentation. Learning outcomes of this track are, first of all, we need to know what is the aim of the primary survey of the trauma patient. And second, the participants should be able to appreciate that primary survey and resuscitation, they go on side by side. And thirdly, what are the various components of the primary survey and how do we carry out this primary survey? So primary survey has A, B, C, D, and E components, and what does this alphabet stand for? So to start with the aim of the primary survey, we need to identify what's killing the patient and resuscitate as well. As you know that trauma is the leading cause of death in the young individuals worldwide, and this advanced trauma life support course was devised to save the life of the trauma patient by identifying those conditions which are fatal within the first few hours after injury, and they can kill the patient if they are not treated in time. So, as you know that the trimodal death pattern in trauma, so in 1/3 of the patients, they have major trauma to the brain, spinal cord, abdomen, or chest. So these patients, they rarely make it to the hospital. And the second 1/3 of the patients are those who have certain conditions in the chest and abdomen, which can be treated in the first few hours. And if they are identified and treated, precious lives can be saved. And the third component of the trauma death is related to the intensive care patients who are admitted in the hospital and they undergo septicemia and death in the ICU. So in the third component of the patients, we can save the life by improving the intensive care facilities. So let's start with the various components of the trauma. So the first component is airway. So whenever we talk about the airway, we always talk about the cervical spine. So how do we assess the airway? So first of all, you communicate with the patient. If the patient is conscious and patient is communicating, that means the airway is patent. If the patient is unconscious and the patient is not responding, that means that the airway can be obstructed. So what are the various steps in clearance of the airway? I will briefly talk about the airway management because this component will be covered by the Department of Anesthesia. So if the patient is communicating, the airway is intact. If the patient is not communicating and unconscious, first of all, you have to open the mouth of the patient and you remove any secretions or any dentures and foreign bodies which are present in the oral cavity, and you remove the secretions with a large bore suction. And similarly, when we assess the patient for head injury, if the Glasgow Coma scale is less than 8, then the patient is going to require a definited airway, otherwise the airway is going to collapse. So these are the various maneuvers like chin lift and jaw thrust maneuvers. I will not go into the details, but you should know these are the various methods of maintaining a patent airway. So if the victim is breathing, do not provide an airway. Establishment of the airway is the highest priority in the primary survey. So we have discussed that you need to inspect for the foreign bodies, any facial, jaw, or trachea or larynx fractures that can result in the obstruction of the airway because of the edema in that region. So techniques which can be used initially for the opening of the airway is chin lift and jaw thrust maneuvers with stabilization of the cervical spine. If the patient is not maintaining airway, then the next step is intubation that can be done by orotracheal or nasotracheal route that will be covered by the anesthesia department. So this is the diagram of oropharyngeal airway. This end of the airway is towards the inlet of the larynx, and this is placed on the oral cavity. And this goes along the curve of the tongue and goes into the laryngeal inlet. So if the tongue is falling back, then this airway can maintain the respiration or ventilation temporarily till the assessment is going on. But if this airway is not maintaining ventilation, then we need to go for the orotracheal or the nasotracheal intubation. And if that is not possible, patient will require cricothyroidotomy. There is a small space between the cricoid and the thyroid cartilage, and through that space, under local anesthesia, a tube is passed into the larynx. So once the tube has been passed, it is connected to the ventilator so that the airway is maintained. This is cricothyroidotomy set. It is a disposable set. You can see the various components. It has a knife. Then after local anesthesia infiltration, it has a dilator as well. Then these are the various instruments which are used for the cricothyroidotomy. It is also known as mini tracheostomy. So we always talk about the cervical spine stabilization with the airway because it is an essential component of the trauma patient assessment. Now the question is that should we stabilize cervical spine in all patients? Because if the cervical spine is unstable following trauma and the patient is not moved appropriately, that can result in cord compression or quadriplegia, which is associated with high morbidity and mortality. So in which patient we need to stabilize the cervical spine? First of all, any patient who is unconscious after trauma or altered state of consciousness, any patient who has blunt or penetrating trauma above the level of clavicles, and any patient with high velocity impact. Now, what is high velocity impact? High velocity impact is impact in which there is significant deceleration after road traffic accident. Various parameters of high velocity impact are if the patient has a fall from 10 to 20 feet height, if the front of the vehicle is compressed by 30 centimeters. Similarly, as you can see in this picture, that there is a rollover, the car is rolled over, and if there is ejection of the passenger from the car, and if there is death of the other passenger in the car and the victim which has arrived in the emergency, you should suspect that it is a high velocity impact. So any patient with high velocity impact, any patient with unconsciousness after trauma, and any patient who has blunt or penetrating trauma above the clavicle needs the stabilization of the cervical spine. So next component of the primary survey is B. And B doesn't stand for breathing alone. It stands for breathing and ventilation. So what is the difference between breathing and ventilation? So breathing is an act of inspiration and expiration, but ventilation is the exchange of gases at the level of the alveoli. So not all the patients who breathe ventilate. So if the patient has rapid shallow breathing after trauma, patient might not be ventilating. That can be checked by pulse oximeter. Oxygen saturation is going to be low. So any patient after trauma, you need to give 100% oxygen with a mask, and you have to check for life-threatening emergencies in the chest. We will discuss later. So the first life-threatening condition in the chest, which needs to be discovered, is tension pneumothorax. What is tension pneumothorax? Tension pneumothorax is a condition in which the air enters into the pleural cavity with inspiration, but it cannot escape with expiration. So gradually, the pressure of the air accumulates in the pleural cavity, and initially there is collapse of the lung, and later on there is shifting of the mediastinum. And in the mediastinum, you know, there are great vessels, vena cava and aorta. So these, when the vena cava is compressed, then the inflow of the cardiac cycle is stopped. So the venous return is stopped, is reduced. So this results in weak thready pulse, hypotension, and on clinical examination, if you auscultate the chest, there is going to be absent vowels, absent respiratory sounds on that side, and the percussion node will be resonant, and there will be significant shifting of trachea. So what we can do once we suspect the tension pneumothorax, once the patient is being transferred to the hospital, or once the patient is inside the hospital and the arrangements are being done for the chest intubation, puncture can be done in the second intercostal space in the mid-clavicular line. That is going to release some air, and then it is followed by the intubation, which is definitely treatment of the tension pneumothorax at this stage. So the second life-threatening emergency is open pneumothorax. Open pneumothorax means there is an open wound in the chest which is communicating with the pleural cavity. So in this condition, we need to place a flap valve dressing which is open on one side so that the atmospheric air does not enter the pleural cavity during inspiration, and that flap valve allows the escape of air to escape from the pleural cavity during expiration. So the third emergency is massive hemothorax. So any fluid in the pleural cavity after trauma is usually blood. So massive hemothorax, again, it is going to cause a collapse of the lung, shifting of the mediastinum, and it is going to cause severe respiratory distress. On clinical examination, the breath sounds will be absent and the percussion node will be dull. The fourth chest emergency is the flail chest. Flail chest is a condition in which two or more than two ribs are fractured at more than one point. We will talk about it later in a little detail with the diagram. So normally during inspiration, the pleural cavity, the rib cage moves outwards, and during expiration, it moves inwards. So this segment between the fractures, it acts as a paradox. So it will move outward during inspiration, and during expiration, it is going to move inward. So it is going to cause difficulty in ventilation because the lung expansion is compromised at that level where the fracture is present. So in this patient with flail chest, if the patient is not maintaining saturation after adequate analgesia, patient is going to need a ventilatory support. And for how long this ventilatory support is needed? Usually it is needed till the fracture segment has stabilized. So it's the callus formation starts. So it usually requires about 2 to 3 weeks, these patients on ventilatory support, and they tend to recover after that. So the fourth emergency is cardiac tamponade. What is cardiac tamponade? Is the accumulation of fluid in the pericardium, which interferes with the contractility of the heart. So in this patient, the patient is going to be tachypneic. There is going to be steady pulse, and there is going to be engorged neck veins. So in this condition, the treatment is pericardiocentesis. How it is performed: ultrasound probe is placed, and the needle is passed, and aspiration of the blood is done. And if it is not settled after pericardiocentesis, it is followed by thoracotomy, and definite control of the bleeding vessels, which is causing the cardiac tamponade. So this X-ray, you can see it is an X-ray with you can see these are the normal lung markings on the left side, and this is the heart shadow, and you can see that this is the air which is present on the right side, and this is the border of the lung. So this is a case of tension pneumothorax in which this is pneumothorax, and you can see that trachea is shifted to the opposite side. So this is the midline, the trachea has a shift over here. So this is a case of tension pneumothorax. This is the diagrammatic representation of flail chest. I have told you that it is a condition in which two or more than two ribs are fractured at more than one point. And this segment is known as the flail segment. It acts as a paradox. It does not move with the inspiration and expiration of the rib cage. So this segment is going to interfere with the expansion of the lung, and it is going to cause ventilatory problems. So these patients, if they are not maintaining saturation after good analgesia, they need to be on the ventilator till the fracture segment, this rib fracture segment has stabilized. This is the diagrammatic representation of cardiac tamponade. You can see this is the normal pleural cavity. It does not contain any fluid. And this is the fluid after trauma. There is bleeding in the pericardium, and this bleeding is going to cause the interfere with the contractility of the heart. So the third component of the primary survey is the circulation and control of hemorrhage. So it is not only circulation, it is control of hemorrhage as well. So control of hemorrhage is usually done in the pre-hospital management in the field when the patient is received by the emergency staff. So any obvious bleeder, it has to be covered with a pressure dressing, and patient is transferred to the hospital facility. Circulation means you need to maintain the IV line. So IV line is maintained usually with the 2 wide-bore IV cannulas so that resuscitation fluid can be administered rapidly in these lines. So if you see that the patient has a deteriorating conscious state, pallor, so a rapid steady pulse, that means the patient is going into shock and patient needs fluid resuscitation. So in the pre-hospital management, usually IV line is not maintained. The patient is transferred to the hospital facility, and once the patient is in the hospital, the intravenous line is maintained. Because there is a concept of permissive hypotension in the pre-hospital management. If we do not, if we raise the blood pressure rapidly, there is going to be more hemorrhage. So in the pre-hospital management, usually IV line is not maintained. When the patient is in the hospital, maintain IV line and start the fluid so that the blood pressure is maintained. And at the same time, blood is arranged and it is transfused when it is required after grouping and cross-matching. So the next component is the D component of the primary survey. And this D component is the assessment of disability. It is important that you should understand that this disability is not the musculoskeletal disability. This disability we are talking about is the head trauma or head injury. So it is the neurological assessment of the trauma patient regarding disability of the brain. So we go through Glasgow Coma scale, and so we have to check the eye opening of the patient, the best motor response, and the best verbal response. And normally it has a score of 15, and in head trauma, the score is reduced. If any patient who has a score of 8 or less, patient is going to require a airway or endotracheal tube. And then later, the assessment for the head trauma can be done with investigations, but in primary survey, you only do the assessment, but do not do the other investigations for head trauma. So the next component is the E, which is the exposure with environmental control. The idea of exposing the patient is that no injury is missed. So the patient should be exposed completely, and patient front should be examined and the back should be examined after log rolling, because we do not know the condition of the spine, and so any condition, any injury of the back can be missed if the back is not examined properly. So this complete examination of the patient, most of the injuries, if the patient has any minor lacerations or bruising or contusions, they can be dealt later in the secondary survey. But exposure with environmental control, that means if the patient is in any cold environment outside, you should not expose them. You should cover them with blanket, and you can examine them under the blanket. So exposure has to be done with environmental control. Then there are adjunct to primary survey. What are the different things, with different investigations which we can carry out in primary survey? So first of all, while the IV line is being maintained, the sample is withdrawn for full blood count, electrolytes and urea, coagulation profile, glucose, and cross-matching of the blood. Because most of these patients, if they have shock, it is a hemorrhagic shock, and the treatment of hemorrhagic shock is blood transfusion. So initially, the fluids are given, and then the blood is arranged and it is transfused accordingly. Similarly, ECG of the patient is done, and for circulation, 2 wide-bore IV lines, we have discussed about that. Urinary catheter is passed to maintain the urine output. Gastric catheter, if the patient is unconscious, you can pass because otherwise the patient can aspirate if the patient has a full stomach. What are the radiographs which are allowed in primary survey? So only the lateral view of the cervical spine and chest X-ray and X-ray of the pelvis. So these are the X-rays which are allowed in the patient with primary survey. Lateral view of the cervical spine to see any fracture of the spine. AP chest X-ray view to diagnose any pneumothorax, tension pneumothorax, hemothorax, cardiac tamponade. And AP view of the pelvis to see any fracture pelvis. Because fracture pelvis is an emergency, fracture pelvis is associated with a lot of bleeding, and usually it is a closed hematoma, and there is significant blood loss in these conditions. So these are the X-rays which can be allowed in the patient with primary survey. The lateral view of the cervical spine, anteroposterior chest X-ray, and anteroposterior pelvis. Another investigation which is now allowed in the primary survey is the fast ultrasound scan. It is known as the focused abdominal sonography for trauma. The idea of fast scan is it is available on the bedside of the patient. So the probe is placed in the epigastrium, hypogastrium, right lumbar, and left lumbar region. Epigastric probe detects any cardiac tamponade. The hypogastrium or suprapubic area probe detects any blood in the pelvis. The right lumbar, any free fluid in the subhepatic area, and the left lumbar, any free fluid in the left subhepatic area. So if there is blood on the right side, usually it is because of the liver trauma. If there is blood on the left side, left lumbar area, it is usually because of splenic trauma. And if there is blood in the pelvis, it can come from anywhere, even sometimes from the fractured pelvis. So ultrasound can guide you if there is any intra-abdominal viscous injury and if the patient has any free fluid in the abdomen. Because most of the time after trauma, the free fluid in the abdomen is blood. So it will help you in carrying out the decision making regarding the abdominal trauma and its management. And we will discuss abdominal trauma in our next talk. These are the few more X-rays. You can see this is the left pleural cavity. You can see the lung markings over here. This is the cardiac shadow. And you can see here a lot of air. This is all black shadow. This is air. And you can see the lung is collapsed over here. This is the lung. This is the cardiac shadow. And this is the lung, which is totally collapsed. At the same time, you can see that the trachea is shifted to the left side. So this is a case of tension pneumothorax. It will require needle decompression of the second intercostal space followed by chest intubation over here. This is another X-ray. You can see this is the normal pleural cavity, and you can see a lot of haze over here. So this is the cardiac shadow. So this is a case of hemothorax. You can see the mid and the lower zone there hazy. So it is again an indication of chest intubation. Thank you. That is all about the primary survey. To revise, primary survey is done to identify and manage the life-threatening conditions which are present in the first few hours of the trauma patient. And primary survey and resuscitation go on side by side. Primary survey has 5 components. Number 1 is airway and control of cervical spine. Number 2 is breathing and ventilation. Number 3 is circulation and control of hemorrhage. Number 4 is disability assessment. And number 5 is exposure with environmental control. Primary survey and resuscitation, they go on side by side. And then there are adjunct to primary survey. You need to carry out the blood samples of the patient, and you need to pass the Foley's catheter, and you need to carry out the X-rays, which are important to diagnose the life-threatening conditions. The X-rays which are allowed in the primary survey are the lateral cervical spine X-ray, anteroposterior chest X-ray, and the pelvis X-ray. So I think we finish here. I hope you have understood whatever has been stated here. Thank you very much.